And we're moving from there to Bill Lukin, who's with us today. And I think, if I'm not mistaken, you're an emergency physician plus a palliative care trained person. Is that right? So I've seen many dual trained people, but that combination I haven't seen very often. But it sounds like it's an increasingly important one to me. So thanks for coming.
I think I'm the first emergency physician and palliative care physician in the country, and that's just because I had a midlife crisis around emergency medicine. So I'll tell a little bit about my story, and Crispin Hajkovic, who's not here today. Oh, Crispin is here. So Crispin's the reason I'm here, and Crispin asked me if I would be interested because I had a take on around the way antibiotics are used in residential aged care facilities. So my journey from emergency to residential aged care was about 14 years ago. We started a service in this hospital run out of the emergency department for patients from residential aged care, trying to get, when they come to the hospital, trying to get sensible decisions about the care that they have. And I was shanghaied into it by a senior nurse because she was given some money to run the service, but there was no medical money, and she'd been kind to me in a previous job as a registrar, and so I thought I'd help her. And what I learned in that space around people who come from residential aged care has totally changed my career, and certainly the way I face people with dementia and people from residential aged care. So I haven't got a whole lot of data to back what I'm going to say, and I'll say a few things that are a little bit controversial, but there is a way of killing every single resistant organism in the patient, and that's to let them die and burn them. Or to put them in a box and bury them at least 8 feet under the ground, and then their organisms don't get into other people. And that's probably the crux of the issue. So Crispin's interest comes about because we use a lot of antibiotics in end-of-life care. There is no evidence about whether we're really helping these people or not. And if it's as simple as we just shouldn't use antibiotics in people who are having end-of-life care, what are the barriers to that? And there's two things I want to talk about today. One around substitute decision-making in families, and one about the doctors and why we have so much trouble not prescribing an antibiotic. And I'm sure Crispin won't mind me sharing this, but he's got a relative in aged care, and he's got some interesting things to say about the way we use antibiotics in aged care. And giving an antibiotic to somebody in aged care, it's kind of what could it hurt? Well, it actually hurts other people in that facility, and there's some evidence for that. And Crispin can show you the paper. It's not fantastic evidence, but at least we can say it's not zero harm, even for the people in the next room. So the two questions are, why do the doctors find it so hard? And I'll talk about that first. Why do the doctors find it so hard not to give antibiotics? We don't like letting patients die. We really don't like it. And we also don't like helping people make decisions that might shorten their lives. We're not very good at it as doctors. So in the residential aged care space, we're very good at doing not for CPR orders. It's easy to do it, and the junior doctors do it. It's really easy. If you're 85 years old and you live in a residential aged care facility, we shouldn't do CPR on you. The reason we find that so easy is that we know it doesn't work. It's a myth, CPR. It's a complete myth that it helps people. The outcome for, if you live in a residential aged care facility and you have a cardiac arrest, the chances of you surviving are so remote that no one would sensibly consider it a therapeutic option. However, we kind of think this is our job. We have to do it. We have to convince the families that they're not for CPR. And do that, and we kind of think we've done our job. And we don't like the next part of the job, which is, oh, well, we're not going to do CPR. I've really done my job, but a little bit of antibiotics wouldn't hurt. They're going to aspirate. And this comes about from the medical misunderstanding of what happens with people with frailty and dementia when they die. And the way we use antibiotics in the emergency department just backs that up. And the way we use it in medical wards just backs that up. So when you're really frail and you've got dementia and you start to lose your swallow and you start to lose your cough, you've got mucus you've got a viral illness, an increase in your mucus, you get a mucus plug, you lose a third of one of your lungs really quickly. Maybe it happened after dinner, and so they aspirated and they go grey and they're hypoxic and they look terrible and they're breathless, and then an ambulance gets called and they come to the hospital and we have a look at you and we think respiratory distress, hypoxia, happened while they're eating. They've got aspiration pneumonia. We'll give them, don't tell Crispin I said that, but they'll get piperacillin tazobactam probably if they look sick, because they're the antibiotics for sick people, aren't they? And this is 20 minutes after they've aspirated. The chest x-ray looks pretty normal actually, but you know, they've got a respiratory illness, so they probably, in fact, we don't understand. They haven't got an infection clearly. They've got if anything, they've got a chemical burn or a structural issue. We give them some antibiotics. They go up to the medical board. The nurses turn them over from one side to the other. They cough the plug up, but they reinflate and they're better the next day. Wasn't it fantastic that we gave them that antibiotic? The oxygen requirement reverses really quickly, much more quickly than it could possibly if you've got consolidation. So we all think that aspiration pneumonia in end-of-life care, in residential aged care, is a real thing. It's actually probably not. People aspirate and they lose large parts of their respiratory function and they're too sick to reinflate. They probably get some secondary bacterial colonisation. And I guess they really do get pneumonia and they die from pneumonia, but much more commonly when they die from that frailty, it's a mechanical, chemical burn in the first instance, followed by mechanical collapse, hypoxia, distress. They often get a fever associated with the distress. So you can see why we think it works. And also we think, well, we've gone through all this trouble of convincing them we're not going to do CPR, but I guess they can have some antibiotics, it's not going to hurt anybody. Which, the reason I'm here is it does hurt people. And so when people really do need an antibiotic, it's really hard for us as a doctor to convince them that it's the wrong thing to do. We don't like doing that. We don't like shortening people's lives. But what I discovered when I started working in the service is when you ask the people who live in residential aged care what they really want, most of them don't want their lives made longer. But we never ask them that question and we're terrible at it. So the question for you is, you know, you come to the emergency department, you look really terrible, we think you've got an aspiration pneumonia, do you want us to save your mother's life? Of course they do, they want everything. So we give them the antibiotics, they go to the ward, they're better in a day or two, they go back to the nursing home, everybody's happy. We treated that terrible pneumonia, we used a bit of pip-taz, but that probably doesn't matter too much. We don't think about what's happening and we don't think about whether the patient wanted it or not. So in a medical sense, it's really hard for us to initiate a conversation where the result of that conversation might be a decision that the person would make that will shorten their lives. Surgery is the really difficult one. And surgeons will tell you this, it's very hard not to operate when you can operate. But you need a skill set where you're able to ask a family and a patient to actually, you don't have to have this operation. We're not very good at consenting people. If you decide not to do this, this is what will happen, and there's a whole way of looking after you. So that's, from a medical perspective, probably why we don't do that with antibiotics very well. Why don't families think about it? So I often ask families, they don't think that they can say no to antibiotics. They think it's euthanasia. And it's not euthanasia, it's the patient's right to say no to treatment. But if you ask the daughter of the lady who's come from the residential aged care facility who's got respiratory distress, what do you want us to do? It's really a terrible thing to say to the person. Do you want us to save your mother's life? Of course you do. Or do you want ICU? Do you want surgery? Do you want antibiotics? That's the wrong question. So the Guardianship Act in Queensland, and it's the same, the principles around substituted decision making are the same in the country. And it's a very powerful thing once you understand what substituted decision making really is, because you want to take the responsibility off that family member. So the daughter will feel guilty. She probably feels guilty because she's the one who bunged mum in the nursing home in the first place. She thinks, oh my God, I wish they'd stop torturing her. But if the doctors at the hospital think she needs to come to the hospital and she needs to have an antibiotic, who am I to say that's the wrong thing to do? So she feels guilty because she thinks, oh my God, I wish they'd just stop torturing my mother. But she can't say that, even if that's what she thinks. So An end-of-life care discussion involves getting the family to a space where they can actually tell you what they think. If it's set up in a combative phrase, which is like, I've got a list of menu options when you come to the hospital and ICU's the box that you've got to tick, that's easy. You know, as I started my career, I just stick the tube down and let Jeff Lippman sort it out. It wasn't my problem. But that's a really terrible thing to do to families, to give them the stress of having to make that decision. In fact, the Guardianship Act tells us, and it's the same around the country wherever you come from, that when you are asked as a substitute decision maker, your job is to tell us what the person would be saying. And I often say, let's go in a time machine and go and get mum from 20 years ago and bring her here and stand here and she can see herself. What is she going to say? And sometimes they say, oh, she'd be saying, hold a pillow on her face. And I say, well, we won't do that, but she doesn't have to have an antibiotic. She doesn't have to have her life made longer if she doesn't want it to. And that's the phrase that we have so much trouble using. Your mother does not have to have her life made longer if that's not what she would want. And if that's not what she would want, we have to hear her voice. You don't have to tell me what you want, because I know what you want. You want your mum back how she was 10 years ago. You want her out of the nursing home and living at home with you. And, you know, that's when they start crying and they start agreeing that actually, yeah, mum would she would hate this. She never wanted to go to the nursing home. She said to me, I am not the sort of person who's going to go to a nursing home. I don't want to be there. And then you say, if she doesn't want to be there, don't take the ticket of exit away from her. But what they're terrified of, if they want to, a family might come to the hospital, they don't want you to do anything, but they're terrified you'll abandon them. They don't want you to just say, oh, if you don't want any treatment, come back to the nursing home. So most of the end-of-life care that you can give, especially in residential aged care, can be done in residential aged care. It's just that residential aged care is going through some transition. The patients are getting more complex. They come out of hospital after really long, complicated medical admissions. Nobody gives a hand over to the general practitioner. Nobody's thought about asking the families what they actually want, not in a sensitive way where they can really tell you what they want. The doctor says, if this happens, you better come back to the hospital. Well, who are the patients to say? But I've discovered when you actually ask them, a lot of the times, if you ask them properly, they actually don't want to have their lives made longer. That's a really crucial question. But they also don't want to be abandoned. And if the answer is, there's another whole way of looking after your mum, and we can come to the nursing home and do most of those things in the nursing home and make it comfortable. And that's not against the law. It's not illegal. It's not euthanasia. And I use the word euthanasia because they think it is euthanasia. It's not euthanasia. Often they will totally change it, and all of this distress will resolve, and they know what they want now. And what they want is access to decent symptom control. So then the next part of that conversation is, so when mum goes back and she wakes up and it's Saturday night and she's breathless and she's blue and she looks terrible, is it okay if you give her some morphine and not ring the ambulance? And she will die probably in the next 24 hours after that. And she might not die if she goes to the hospital, but if she's decided that she wants to stay there, is that okay? And when they say, yeah, that's what we want, then you'll be successful at keeping people in the facilities getting the care that they want. But the drugs have to be written up, because the after-hours doctors under no circumstances will prescribe opioids or end-of-life medication. So if the GP hasn't done it, or if we haven't, as the hospital, given the GP the permission to write those medications up, it won't happen. They come to the hospital. And an extraordinary number of people don't want their lives made longer when you ask them correctly. And you've got to do it in a way that, you know, if you want to come back to the hospital, you want to be intubated, I'll be on the phone to Prof Lippman and tell him. It's, you know, it's not about denying patients care, it's about giving them the opportunity to really ask questions properly about what they want and what they don't want. Because when you write vague things like no invasive treatment in a, you know, I've had the experience of walking into the ambulance bay watching a 97-year-old demented person have a bag and mask held on the face by the ambulance officers who were breathing for them at 6 o'clock in the morning, being pulled out of their bed. I'd call that invasive treatment. And yet they had an advanced care directive that was written that same day by the family and the GP saying they didn't want invasive treatment. But we kind of think of invasive treatment as a tube being put in somewhere and going to ICU or CPR, not should you have an antibiotic, because it'll make your life longer if it's given for the right indication. And if that's not what you want, we shouldn't do it. I've come from a house today where I pulled the ARP out and on it, it says IV antibiotics, IV fluids, ward-based cares, not for ICU, not for CPR. And this is in somebody's house who's discharged themselves from hospital because they got completely sick of what was going on in the hospital. It's a woman with severe dementia who's living in a nursing home with a terrible quality of life. His family's decided to take her home, and you can imagine all the fraughtness and the guilt when we get into the house. And this is what the ARP still says: IV fluids, IV antibiotics. We just don't think about it not putting it on there, but it has to be on there, and it has to be asked in a way that gives the family permission to tell you what they really think. Because if they want them to go back to the hospital and have antibiotics, that's okay. It's not, people, we would never say you can't leave a residential aged care facility. Once you're there, you can't come back to the hospital because, if somebody breaks their leg, they've got to come to the hospital. If somebody gets pneumonia, there's so much more to treating proper pneumonia than just giving them an IV antibiotic. So a hospital in the home solution where somebody goes out and squirts a bit of antibiotics into them twice a day when they're in the residential aged care space, it doesn't work. So we don't use that in our service. We really don't do IV antibiotics in the nursing homes because there's so much more that goes on in that building over there compared to a residential aged care facility, other than just the ability to squirt some antibiotics into somebody. I think that's probably all I've got. Any questions?
I'm going to take the chair's prerogative. So in a bit of a devil's advocate question, in the last 2 weeks on both sides of the spectrum, being a practitioner or a family participant in these type of discussions, the discussions took 1 hour and 15 minutes. Yeah. So in the context of 4-hour admission targets, bed ramping and emergency services care, how do you think we can optimally provide quality care for people to make the decisions that they feel empowered to make, either on behalf of themselves or their loved ones?
So it depends on the way you use your emergency department. And so even from a hospital in the home perspective, 4 hours is not enough. So we use our short stay ward. So I admitted a guy last night into our short stay ward down in the emergency department. He hasn't got an infectious problem, but it enables us to use our short stay ward. We've got 24 hours to see what's going to happen and to let families decide. If we have appropriate cooperation with the physicians within the hospital, the same thing can happen in the inpatient space. You're right, it very rarely happens right on the floor of the department. But often you can identify those patients very quickly. If you're from a residential aged care and you've got severe dementia, and dementia changes everything, the more time I spend with people with dementia, it's a really fascinating, beautiful, weird, strange disease that we don't understand. But if you've got dementia, it's very likely that what you want around your care will be different to what people without dementia have. And the beautiful thing is you can ask people without dementia what they want. And you ask 98-year-olds who are still cognitively intact what they want, often they say, just let me go. Second to that is that we shouldn't let the constraints of a 4-hour emergency target change what we do clinically. There's a whole lot of, the problem is not that we need 4 hours to decide if the person needs to come into hospital or not. We've discovered that when we make a decision that the person needs to come in, it takes us, the problems are, and this isn't necessarily infectious, but we discovered when we looked really closely at this, the problem was it took us an hour to tell the nurses, and it took the nurses another half an hour to tell the bed finders, and then it took the bed finders 3 hours to find a bed. So we had zero chance. So early decision making by senior consultants and the decisions sent to the bed finding people within the hospital. So we've got the luxury of having a pretty big short stay unit. So these patients, they can have an antibiotic in the first instance. And so I don't want to interrupt the process whereby if somebody comes to our emergency department and they got a hematological malignancy and they're septic, and the chance of them surviving is entirely dependent on how well we perform. So I don't want too many people to stop and think, I shouldn't give an antibiotic to this person. So if somebody gets a dose of antibiotics, I don't really want to interfere with that. The only problem is a lot of people get urosepsis from nursing homes and they get one shot of gentamicin and that's enough. They survive from unconscious, barely breathing to walking again. It's just astonishing. But I don't want to interfere with a process that is, really important around survival for people who are dying from sepsis when they present to the front door. But that doesn't mean we can't decide that the second dose is a bad idea.
Any other questions? Probably time for one more.
It's great to look at what's happening in nursing. I thought it was sense, and it's quite a lot of data now showing that in hospitals as well, we're in centre. It's not looking in the last week or days. So, studying and changing diets, sometimes patients sitting in once in the last 24 hours, one very large patients from every one pathways to one line into it.
That's probably a fault of us, both palliative care and the general physicians, and I mean that as the doctors in general, is that feeling like we're withdrawing all this stuff, but we'll just leave the antibiotics because maybe it's going to help. I think with this feeling that if you're dying from pneumonia, maybe an antibiotic would make you more comfortable. I don't think the evidence for that is very good, and certainly my experience is you can make people comfortable without antibiotics, and it's the same for urosepsis. But it's that we feel like we don't want to abandon the patients either. The general acute medicine, not the palliative care physicians, getting palliative care in a bit earlier to say, actually, we should stop that antibiotic is not what they want. No one's actually said, do you want your life made longer? Because this will do that. That's an education. There's still a perception that healthcare comes in, everything stopped, the patient dies. They're not really well looked after. It's a whole complex abandonment question. As you, as the physician in charge, able to say, this is the wrong thing for you now, and this is another whole way to look after you, and also having that experience with that conversation. Do you really want mum to be? What would mum think? Does she want us to make her life longer at this point in time? If not, let's stop. And then we shouldn't be giving antibiotics to people that they're not working for. If they actually haven't got pneumonia.
Thank you so much, Bill, and thank you to all our speakers.